So my talk is mechanical thrombectomy, different techniques. So what is actually target for the mechanical thrombectomy? First is open up the artery, okay, and which we are doing for last 12, 13 years now. First with the stent, the later on with the aspiration. Then just opening the blood vessel is not satisfy the results. We have to open up that artery as early as possible. That means the first pass effect. So people started doing combination technique, okay, using stent with aspiration together to improve the first pass effect. And first pass effect is not like sufficient if there is some distal embolization. And how to prevent that? Then third thing come in the picture, that is the balloon guide catheter, okay? And the last, no new artery embolization. And that only you can prevent if you know how is the other good collaterals, like the left, if the left is blocked, the ACOM is there or not, PCOM there is not, okay? So before doing the thrombectomy, you should know other collaterals, other circulation of the brain by doing the CT angio or on the DSA table. And the last, which is very, very important, at least in this part of India or OLR in India, the cost. If you are using all these three and four things together, the cost may be in a 7-digit. And it will be difficult to perform the thrombectomy in the best of the best center. So, knowing the PCOM and ACOM before doing the thrombectomy is very, very important, how you are doing your thrombectomy in those patients. So these are the days when I started the thrombectomy in 2013, 14, and 15. So we used to place 6F envoy in ICA, then microcatheter, close the microcatheter wire, and the stent retried deployed, and whole unit we used to remove, and again we have to place, okay? So these are the days. Then long sheath came in the picture, and we started using those. This is the anterior circulation that's done in the 2015 Valentine Day. And topobasilar occlusion, one pass, arteries opened up, patient did well. Now we have the lots of options available, different stent, different aspiration catheters, different combination techniques, double stent with the aspiration. Then sometime we need to do the angioplasty directly if we know the patient is having the stenosis, significant stenosis. And then sometime even stenting is not sufficient, plasty is not sufficient, we have to place the stent. So these are the methods which we are doing these days to open up the blood vessels. How many are doing the stent retriever as a first, and how many they choose aspiration as a first? So almost equal. And how many are just combination as a first technique? And how many double stent only? Sir. Okay. So I prefer to do aspiration, which I like actually. You may not be agree. If in 2 times I am failed, then I use the combination technique. In difficult navigation, difficult access, then I prefer to go with the combination technique. Or for MVO, up to M2, if the artery is straight, I go with aspiration. And if the tortuous artery, like an MCA, going distally, then my preferred choice in MVO is a stent retriever. So these are the material which needed, okay? So I started the 6F femoral sheath. Now in each and every case, we take the 8F sheath, okay? If you are using long sheath and aspiration, or long sheath aspiration with the stent combination technique, but you want to use the balloon guiding, okay, then you have to take the 9 French. Now the few balloon guide available which can go with the 8 French, but aspiration catheter will not go with the 8F guiding, balloon guiding. So you have to keep in mind. So balloon guided, which are available right now in India, the Cello, Mercy, Flowgate, and Walrus, which is recently launched in India. Then we have the intermediate catheter from the different company. Almost all company now have the intermediate catheter. Microcatheter, 21 or 27 for the large vessel occlusion, where we are using the 6 mm or 4 mm stent retriever. And for the MVO, where we need the 3 mm stent retriever, you can use the 10 or 17 microcatheter. Then microwire, so many microwire available. Stent retriever, these are the combinations usually available. Now we have the 650 also. Aspiration syringe, I prefer to do the aspiration with the 20 cc syringe, but aspiration pump I never used. But people are doing with the aspiration pump. And sometime, because we are in Asia, we have the significant amount of the ICAD. So some patients need a cardiac balloon, stent, and sometimes with the tendon occlusion or IC occlusion because of steno-occlusive disease, we need a carotid stent or balloon. So this is the case I'm going to show you. You have seen real-time aspiration in a simulator, how the catheter is aspirating the clot. And in this case, I'm going to show you real-time capturing the clot by the aspiration catheter. So you can see the dot sign over here. So this is the first angiogram I took from the carotid. Unfortunately, the clot taken the contrast. So you can see the clot there. And this is the angiogram. You can see the inferior division after the first branch is occluded. So it's a straight artery. So my choice is aspiration. You may prefer going with the stent retriever. Combination is not a good technique because taking so much material to the so distally. So this is a clot. So how I am going? So this is my aspiration catheter. Going with the snake technique, hollow tube, no support, no microcatheter and wire, and bang into the thrombus. Okay. So we want to keep the aspiration catheter at the base of actually thrombus. If you're going inside the thrombus, you are destroying the thrombus. You are fragmenting the thrombus. It's okay if you have fragmented the thrombus, it's okay. Okay? But you should not pull the aspiration catheter beyond MCA. Otherwise, the fragmented portion of the thrombus may dislodge further. So even you bang into the thrombus, be careful while pulling back or while aspirating. You have to be very slow, like in this case I did. So I started aspirating very slowly with a 20 cc syringe. The first portion aspirated, now the second portion of the thrombus is also aspirated. My catheter is there in MCA, okay? And this is it took me around 7 minutes to open up the artery, okay? So this is the way you can open up the artery. When you are using the stent retriever also, as soon as you open up MCA, there is a flow from the opposite side if ACOM is there, or there is maybe flow from ICA. And if it is a fragmented there, it may dislodge. So be careful. That's why we started using the balloon guide catheter when we are doing the thrombectomy. So these are the two fragments which came out, and the dot sign went away. So in aspiration, actually, when it was described, first you have to place the long sheath, then intermediate catheter, then microcatheter and wire to cross the thrombus. Then you advance the aspiration catheter to the thrombus. But I told you, I usually go with the snake technique. My aspiration catheter is going up. And from now we reached to the MCA, clot were removed, arteries opened up. only one pass is needed. Coming to the stent retriever. So this is the balloon guide. MC is occluded. You cross the thrombus with a microcatheter wire. Then you deploy the stent. Once you deploy it, wait for 4 to 5 minutes at least. Allow your stent to capture the thrombus. Once it is captured, as a whole unit, you bring it down to the aspiration balloon guide because a wide bore catheter. So no need to remove the balloon catheter, and you can suck it out, like in this case. These are the simple aspiration and stent retriever technique. Now coming to the different combination techniques. So the first is the Solumbra. You can see the art technique in which you place the long sheath or balloon guide, then advance the aspiration catheter or intermediate catheter as a triaxial system. Then you cross the microcatheter wire. Then you advance the aspiration catheter. Once the blood is not coming from the aspiration catheter, you sucked it out inside the long sheath, like in this case. So terminal ICA, MC occlusion, one stent, this is the aspiration catheter, and one pass, artery is opened up. Then the second technique, that is called save. There is a slight difference between the art, save, and capitiva. In this, they have used the balloon BCG catheter. They first place the balloon catheter, then triaxial system, open up the stent retriever inside the thrombus, inflated the balloon, aspirated by the aspiration syringe, 20cc syringe. In a save technique, they deployed first stent retriever, 2/3 of the stent retriever beyond the thrombus. Okay? Then advance the intermediate catheter over the wire till the base of the thrombus. Then start aspirating from the intermediate catheter till the blood is coming. Once blood stop coming means the aspiration catheter mouth inside the thrombus. Then start aspirating from the long sheath, and as a whole unit, you suck it out. That is called the save technique. Now the capative, in which they advance the microcatheter through the thrombus. Then before deployment, they started aspirating till there, and then deployed the stent, and then so there is some difference in all the three techniques described by the different individuals. And you can see, these are all studies done with the stent retriever. These are all 4 studies done with the aspiration catheter. And you can see the revascularization rate were significantly high where the combination of the technique was used. Now coming to the fourth technique, that is the double stent, which usually we use. I have never used actually in last 12, 13 years of my career. If in a 3 or 4 passes you are not able to open up the MCA and there is no IKIT, okay? So there is a 2 technique, where the stent in stent, you deploy first stent, then take over the second microcatheter, deploy another stent, and remove as a whole unit. Second, the parallel stent. So 2 microcatheter first, then deploy both together, and then remove. That is the parallel stent technique. This is the case I borrow from Dr. Tilochan sir. So it's a supraclinoid ICA occlusion, where he deployed the 2 stents, one in the ACA, one in the MCA, and the clot was removed, and the artery TK3. So these are the different stent technique, double stent technique, by which you can open up the blood vessels. One more, that is the double stent and aspiration technique. What exactly happened with the intervention guy when they were doing the stent retriever technique in particular patient? There was a white clot actually at the bifurcation. So they did first from inferior division. So in that situation, the the clot was pushed upward and it didn't capture. The second time they did from the superior division, then the clot was pushed downward. So what they did, they placed a two micro stent retriever in the two branches and advanced the aspiration catheter and capture. So it described as a double stent aspiration technique. So these are the technique which people are doing for the thrombectomy, but still I love aspiration only, even difficult access. If I can cross the cavernous segment without anything, my aspiration catheter, my first choice is the aspiration catheter. Like in this case, you can see the significant tortuous artery. Still, the aspiration catheter is going at the terminal ICA, then MCA. At the bifurcation, the clot was removed, and the TK3 was achieved. I'm using as a first combination technique where I think the going multiple time in artery will be difficult. Like in this case, you can see the significant loop, then the second, then acute angle in the cavernous sinus and going to the MCA. So I took that time long seat, then aspiration catheter. First I advanced the aspiration catheter, as usual I'm going. And it was not crossing the cavernous segment. So even for the support, I pushed forward, upward, long seat. Still it was not going. So I need to go with the microcatheter wire, which is actually described for the aspiration. Once I taken the second microcatheter and wire, so I reached the MCA. So then in the one of the branch, we advanced the microcatheter, and with the push forward pressure technique, deployed the stent, and as a whole unit aspiration catheter, like a combination, we removed in the seat, and the arteries opened up in the two passage. Another cases why I use combination technique is really dangerous ICA, because there is aneurysm. So going blindly, I may damage the aneurysm, and again significant loop reaching to the MCA will be difficult with the multiple time. So in this kind of the patient, I usually go with the combination technique. Again, same way, reaching to the petrous cavernous ICA. And in this case, crossing the cavernous was not a problem. Problem was ectatic artery before the cavernous segment. If you see here, it was really difficult, even that aspiration catheter, intermediate catheter bent. Reached to there, and this is the stent here. This is the aspiration catheter, and the artery is opened up. So in MCA, I usually with the aspiration catheter. If it's a difficult access, usually with the combination technique. Lots of thrombus, probably immature or plaque is ruptured, formed the thrombus, completely occluded the ICA, and I aspirated first from the long seat, then aspiration catheter. But I burned my hand in two cases, similar kind of the cases. Okay, so I prefer to use the balloon guide in these kind of the cases. Once you open up partially this kind of the ICA, there is a chance that some of the thrombus may go up, because now the MCA is occluded. It may go in NCA. If ACOM is open up, it may go second MCA, and you can have the bilateral MCA infarction. So if you see these kind of the ICU occlusion, the lots of thrombus, better to use the balloon guiding to restrict the flow and aspirate these kind of the thrombus from the ICA. And if patient is having the steno-occlusal disease, This stenosis is going to act as like a balloon, because this stenosis is going to occupy by the long sheath or aspiration catheter. So blood is not going to go beyond if the catheters are there. Okay, so in these cases it may not require, but in the previous case where the lumen is clear, just full of the thrombus, if you partially remove the thrombus, the remaining part of the thrombus may go up and block the new artery. Sometime we can face the problem, like in this case, when I was advancing, my aspiration catheter was not going beyond cervical ICA. Okay, it was not going beyond ICA. So when you feel a resistance going in ICA, don't go further. And the second thing, when I doing the aspiration, don't do repeated angiogram in between till you clear the artery. Okay, if you are doing the angiogram between, you may dislodge the thrombus further. So whenever I'm doing aspiration, I go blindly. I know where is the cavernous, where the petrous, where is the MCA, clean up the completely first, then take the angiogram. So after the first angiogram, the second angiogram, only I am reassured that the artery is completely open up. So in this case, it was not going. What do you think? What is happening? Dissection. This lady actually had a baby. So she was in the postpartum period and had a stroke. So it was a postpartum ICA dissection. You can see the long ICA dissection going up. So it was difficult to navigate the big catheter. So I decided to do the stent retriever. So after the first pass, okay, the stent is there from terminal ICA to MCA. Partial is open up, and then complete MCA in a 2-3 passes. But what exactly happened? Some of the clot went into the ACA. What should be done? Should I open up or should I left? Why? 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 Yeah, one is the disability. Again, we don't know how much brain I saved. If I'm leaving this ACA, I'm increasing the size of infarction. Probably after the thrombectomy, this patient going to need a craniotomy immediately. So doing the thrombectomy, I don't know how much I saved the brain, but leaving this, I'm increasing the size of infarctions. So better to open up this artery. So again, going in the smaller artery with a bigger, larger stent retriever is not a good choice. And you can use a larger stent retriever as a smaller retriever if you are partially opening this. So it was a 630 stent retrievers. I have opened up half. So it acts as a probably as a 3/10 or 3/15. Okay? And at 2 passes, the artery was opened up. So in India, we don't have choice to use the multiple things together. So this is the way, if you open up the artery, if there is a distal embolization, you can use the same stent for the smaller artery by partial opening these arteries. Otherwise, mostly, like in the primary distal occlusion, like in the M2, M3 occlusion, I'm going to use a smaller stent. So I deployed the smaller stent that is done around 16 or 17 actually. That time the Codman having the Revive stent, that is, it was a closed stent, 4/20. So I deployed the stent, and in a one pass, the middle division was opened up, and it was supplying the motor strip. Small amount of the clot came out from in the thrombectomy, and arteries opened up. So this is about the different technique at present we are using. Now coming to the okay, it's okay. So this is the tandem lesion, okay? So our target is to open up the MCA, not this one, but we will not able to reach there before opening this. So better to do the balloon angioplasty. When you are keeping after the balloon angioplasty, mostly that long sheath and aspiration catheter going to smoothen this angioplasty segment. And after this angioplasty, you go and open up the artery. If you achieve the MCA opening, what should be done next? Should I place something or leave it? Huh? Did the balloon angioplasty, that's why the never stent. If you achieved significant amount of flow, and if the surface looks like this, not a hazy, and wait for 15 to 20 minutes. If it is not reoccluding, leave that and do the stenting after maybe couple of days or after a week, okay? But sometime, like in this case, you can see the hazy, badly looking even after the angioplasty, where the artery was reoccluding again and again. I have to put the stent. So you should use the stent if the artery is reoccluding. Better to wait for 15 to 20 minutes after the balloon angioplasty, both intracranial as well as extracranial. It's a good case. This patient presented to this time with a left ICA stroke. The right was asymptomatic. Why it is asymptomatic? Because of the good ophthalmic collateral supplying the intracranial circulation. But this time, it was not sufficient, and he came with the right side hemiplegia and sensory aphasia. So we did empty angioplasty and stenting. We were knowing there is a stenosis just prior to the ophthalmic artery. So you can go blindly up to the cavernous segment. Okay, you are not going to do any harm. So same way, the long sheath, aspiration catheter, clean up the completely artery like we did. Okay, then cross the wire, did the angioplasty, then place a stent. He was on the antiplatelet already, so there was not a problem. And he did good. Another similar kind of the case where we did the direct stenting. Okay, you can see the anterior view, AP view, and the lateral view. Again, ophthalmic is supplying, reforming the ICA, but again, the collateral is not sufficient to maintaining the perfusion. So in this case, we cross the wire first, directly place the stent. So in a certain situation where you know this patient is having the stenosis, significant stenosis, and you can place the stent directly. Posterior circulation, again, aspiration. Recently, 2 trials have been published where they have clearly shown aspiration is better than the stent retriever. So this is the aspiration catheter going up and aspirating the 2 passes, the clot was removed, and the artery TK3 achieved. I'm going to show 2 cases, nice cases. Young boy, he was playing tennis in the morning hours, and during play, he had a stroke. Right side hemiplegia and aphasia. So they immediately went to some hospital where the thrombolysis was done with a TNK, then shifted to our center. So this is the MRI. You can see that the ICA is completely occluded on the left side. We took this patient directly to the cath lab. This is from the neck CC angiogram. Okay. And this is the intracranial. So there is something there, and beyond the occlusion, there is a flow. So the partially occluded thrombus, and beyond there is a flow. So what are the choice we have in this patient? What you would like to give the remaining TNK here? Or you want to aspirate? You want to do the stent retriever? You want to go for the combination technique? What is your choice? Yes, I want to know. Okay. So suppose we place a balloon also, we have to cross this clot. And during that, it may disclose further. Pardon? No, I'm not started yet. Huh? I'm just asking from you. Okay, so I decided go with the combination technique. Okay. Reason is very clear. I can cross this lesion with the micro wire easily. Okay. And if I go with the aspiration and if it disclose further, it will be more difficult. So I want a distal protection together with the proximal protection in this case. So this is the micro wire. This is my aspiration catheter. Not crossing again the cavernous segment. I need a microcatheter and wire to cross the cavernous segment. So, okay, you can see that before that intermediate catheter before the cavernous segment. So I cross the microcatheter and wire. Then I deployed the stent across the whatever that is there. And the perfect position is okay? Or some mistake I did? I think it's a perfect position. I'm just base of my aspiration catheter, add the thrombus, close the microcatheter and wire, deployed the stent. Nothing happened. I did 3 times, same technique. Then I thought, better to use Dr. Tilochan technique. But before I thought better to use the same way I'm doing the aspiration. So, yeah, so I cross the lesion, whatever it is there. And in between I was thinking there is a terminal ICS stenosis and plaque has ruptured, which is there at the base, at the osteo of MCA as well as ICA. I've never seen this kind of the case. Okay, so I thought better to do the aspiration first, and we'll try the angioplasty or double stent, whatever. So I went beyond the occlusion site and started aspirating, and this did work, and this came out. Why it was not coming out? Because of the hard material. It was not capturing from the stent. Okay, and it was actually atheroma. So it's ruptured from probably from the aorta during when he was playing and went up. And we did the biopsy of this material, and it was a cape, actually atheroma cape, went up, and arteries open up. And probably this is the site. You can see the extra contrast was there in the aortogram, which I usually do whenever I do the angiogram. You can see the stasis. Probably there is a site where the atheroma ruptured and went up. And this is the patient who recovered completely. He is having some motor aphasia, otherwise the guy, he is absolutely normal. Another case, similar kind of, in the one pass with aspiration, again, you can see atheroma. So it's not always what you see is a clot. You can have the atheroma. You can have the panache from the heart, particularly heart disease patients, valvular heart disease patients. So if it's not coming, think about something else and try something else. Young patient again. Again, for the audience. So this patient came with a mild motor aphasia and slight motor drift from the right. Okay. So anybody, what is your choice of treatment in this patient? So I explain you. There is a severe stenosis over here. Beyond stenosis, there is a normal blood vessels, looks like a dilated MCA. And there is a floating thrombus, and beyond that, all the branches are filling. He is having some deficit with the motor aphasia. Anything? Huh? Are you thinking you will cross this stenosis with the wire and microcatheter and it not disclose, going to disclose further? No, it's around 7, 8. Suppose it's 6, you want to leave? Well, that's good. Vessels is flowing nicely. No, I have done actually something. Vessels is there. All the branches are filling nicely. If you are doing the balloon plasty, definitely you are going to damage 101%. Yes. Yes. I have given 15 milligram of TPA over the period of 10 minutes. It dissolved completely. Completely. So in the real world, what we see, how the IV thrombolysis is working, I have few cases of this kind where there was a floating thrombus and there is a stenosis, given intra-arterial thrombolysis, and it did work actually. Yeah, I'm showing. Okay, so it's not a severe stenosis. It is around 50 to 60, maybe 70% stenosis, but it was a vulnerable plaque, formed the thrombus, ruptured, and beyond that it was not a significant flow. So clot formed beyond the thrombus as a floating thrombus, and it was symptomatic. And TPA did work. Even I have not done the angioplasty in this segment. I put on a high dose of atorvastatin, and he's okay. Double antiplatelet for at least 3 months. I have started immediately because I have given only 15 milligram of TPA, not full dose. 15 milligram of RT. Yes. No, tablets. Another patient who had a stroke, presented with the actually TIA. As usual, in all emergency, hypertension, patient is going to admit where? In my hospital cardiology. I don't know about you. The same way, missed by the TIA by the emergency guy, admitted under cardiologist, started anti-Z. In the mid of the night, he worsened. They did MRI. Okay? So what do you think? Again, lots of clue on just MRI. How should I go now in this patient? What do you think what the patient is having? MCA is occluded on the right side. He was symptomatic on the left side where you can't see even the left ICA. So if the multiple vessels is not seen, patient is having the steno-occlusive disease, probably ICAT. Always think. Okay? So I was prepared, this patient is having the steno-occlusive disease, I have to go in the same manner. Okay, so this is the first angiogram from the left side. Now, IC is not occluded from the proximal segment. It is terminal IC. So, same way I usually go, aspiration, but people prefer, if you like in some literature from the Korea and China, they prefer to do a stent retriever thrombectomy in ICAT than the aspiration. But still I feel that aspiration is going to work the same way, in a better way, because we are not damaging actually plaque. If you're not damaging the plaque, the thrombosis chance will be less. So I aspirated. Okay, so I started aspirating and pulling back the aspiration catheter. Arteries opened up. These were the material came out in aspiration, white radius plaque material, not spiral plaque, as you can do the red thrombus. But again, after a few minutes, reoccluded. So whenever there is a inflammation is going on in the plaque, there is always chances of rethrombosis. If you are doing the thrombectomy by stent retriever or anything, you are damaging more endothelium, again increasing the chances of thrombosis. So better to do first suboptimal balloon angioplasty. Okay, so same way I did the balloon angioplasty with the 2 and 12 mm of the balloon, but it didn't work. Again, the artery was reoccluding, so I have to place the stent. So coronary stent, and after the placement of the coronary stent. So this is the last view. This is the patient. So it's okay. Otherwise, I have few case in box stroke patients. If it.
I think it's been a long day,
Yeah.
and we have seen everything. So maybe tomorrow we'll continue with this.
It's okay.
Any questions
Thank
from
you.
the
Thank
audience?
you so much.
Any questions? Any comments from the audience? From anyone?
Once you put a carotid stent in a tandem patient, like how late will you constitute the antiplatelets?
So yeah, you have to start immediately. So we load with the Brilinta 180 milligram and aspirin, and wait. If it is in 20-30 minutes, if the thrombus is coming, we have to start the tirofiban, which I usually do.
This is for the carotid stent.
Any stent. Yes. If you place the stent, you don't have the choice. Stent is not allow the vessel to flow if your patient is not on antiplatelet. It is very, very unlikely. And usually what we have seen, patients who are having the steno-occlusive disease, they don't have the big infarctions like in the embolic stroke. Okay? So you place a stent, start the antiplatelet, maintain the blood pressure less than 120 in the most of the cases, and it works.
The typical cost of these procedures varies from maybe around 3.5-4 lakhs and can go up to 8-10 just for the procedure, depending on the number of hardware that we use.
Yeah, that's why I prefer to do with the aspiration, because that is the cheapest technique to remove the clot.
Yeah. And it is very unfortunate if you spend that much and then the patient does not do well. So that's why that also has to be kept in mind, at least in our setting. Every private setting, that is the case. Dr. Tilochan does double stent retrievers. I think it will cross 12 lakhs.
But he's getting probably free of cost, huh? Is it?
He's getting free of cost. Chalo. Very nice on the part of the audience that you are still here at 6:37 in the evening. Thanks a lot to everyone, and let us break now, and we meet again tomorrow morning at 9:30 when we start the session on the orbital angioanatomy. Thank you.